back in the day, I found it would probably be something that we in the Caribbean would light up to, as opposed to moving around with the nitrous oxide, the CO2 ablation technique. I'm not here to I guess promote WESAP, but I bought that machine when I left Scotland as a resident, and it's well over almost 25 to 30 years old, and it's still working. So we have now progressed. We now have the thermal. We now have portable colposcopes, and I happen to be in a foundation that's being done by Bill Clinton, and those trying to find out which AI program with a smartphone in those areas around the world who have to use VIA techniques to develop and portalize this whole system so we can achieve the goal and eliminate cervix cancer. I don't need to use the statistics in the Caribbean. We know they're awful. Even I, who come from the Bahamas, where we have resources, is still awful. So being the president has afforded me the privilege to use some of my leverage to try and see if I can get all my colleagues in the Caribbean to get there. First of all, become an official mentor. Once they become that, just imagine when we go back to our ivory towers, if we train our colleagues locally, all the residents who are coming through our DM program, if we get them trained, you can then spend more hours in the ivory tower doing all the big surgeries and doing all the wonderful things you've learned to do. It's better to get the foot soldiers in the community to lift that load for us. So it's my pleasure to have all of you here and to welcome you to this workshop, which the IGCS has allowed you to have free of cost. And so to you, Susan, I thank you very much. And to you, Doc, I thank you very much for giving up your wonderful time to leave Texas and be with us in little old Miami today. Thank you.
So it's so nice to see new friends, but also old friends, right? We were together for so long. And that, so as we said, the idea for today is for everybody to try to be as ready as we can to be mentors. This is the idea of the pre-invasive program for IGCS, not to train one person, but to help the country, right? So everything that we can do, even after this, after the course, you please just let us know. We'd like to also say thank you to Dr. Ida Ismail Prat. She's our partner in crime. She also helped with the whole program. And she's from Singapore, so she could not be here today, unfortunately, but she's in spirit. So I think what we can start doing is, I just have an easy question. If everybody here does leaps, everybody? Or is there anybody who does leaps usually in clinic? Okay, almost everybody. And thermoablation? Just some, yeah. Okay, colposcopy, everybody does or no? Who does colposcopy? Almost everybody. Okay, so if we are saying something super basic, the idea is not, of course you know, but the idea is how you teach these skills to somebody else. So always stop us. We love questions, so ask questions. And this is a refresh. We know that the majority of you did phase 1 and phase 2 for the program. So the idea for today is to give the opportunity for questions, because we know they are only videos, right? So we do these courses, we refresh the content, but the main idea is to open for questions, okay? So just stop us and make questions, please.
The gist of what we face in the region, in the Caribbean, is our rates are excessively high. We have national health systems that are not completely well funded. Patients have to procure or get medical treatments in low resource center with funds from the government which are not adequate enough so that the background rates of abnormalities in the cervix are extremely high. We appreciate that the only way to go forward is, one, to get more leaders and more people to advocate in the community through our cancer societies to influence the governments. One of the objectives while I'm in this presidency is to try and see if I can get Tim Goopersing, and unfortunately I lost Hubert Minnis, who would have sensitized the Caribbean, or if CARICOM governments, to appreciate that we must fund this system. The numbers are appalling. Patients fall through the cracks. And my good friend over here from Barbados, we were recently, this society was contracted recently to write some of the screening protocols for Barbados. We participated. We gathered PAHO, took the work that we did as a team very, very well. So if the Caribbean Gynecologic Society can get a place at the table, then we can make the impact in our communities. We are hoping that through this course, as you become more and more expert in this area and train others, you won't have to spend the time worrying about the pre-invasive disease. Certainly we know that we all want to eliminate cervix cancer by 2023. PAHO has put out the 90, 70, 90 elimination of cervix cancer. I think most of you see it blown up everywhere on the IGCS site, so I won't spend time talking about something that we all know. Hopefully, as we, mean us all in this room, if we can go back and sensitize and train a fraction of our colleagues, and perhaps, is controversial, maybe even down to midwives, we may be able to make the impact. I've been fortunate that I go to Ghana. We have a program going very well in Ghana, in Bator. They train almost, or we train, and it's well funded now because internationally money comes in. They cycle in 20 to 30 midwives or healthcare assistants, and they are lifting this banner to procure and send people all up and down the remote areas of Ghana. They have no technology other than VIA. I'm concerned about that, but we are pushing in the back room to develop a test similar to as a pregnancy test that you walk in a room and in no time you can have an HPV result. Just imagine if all of that moves into your area. So you would be able to know you have high-risk HPV. You would be able, hopefully today, to learn with all this new system, you can destroy that transformation zone or that area of dysplasia, and you may have that impact for us all. And almost every society I know, the ESGO, the IGCS, the SGO, the American Society of Colposcopy, we are all partnering in this internationally. And it is our hope that the one thing that if we could also ablate pre-invasive disease and get the governments to fund vaccines, we could achieve that goal. So I was fortunate in my career to be able to bring the vaccine with one of our CMOs to our country. So I'm hoping that that would bear fruit. And I think my 10 minutes might be up. And I think I wish you all well, but I just want you all to think about the things I've said. And if I could get just a fraction of you to carry those skill sets back to where you've come from and to pass it on to all the residents, the midwives, the doctors you work with, we could probably do this and make the English-speaking Caribbean look much better than the numbers internationally on IOC site demonstrate we are. Sub-Saharan Africa is awful. We all know South America, the cervical dysplasia and cervical cancer rates are too high. If Australia could now prove to us that if we vaccinate, and now beginning to tell us it may not be 3 doses, we can get away with 2 if you are under the age of 12, or we might be able to get away with 1. Just imagine where the world would be for the future. So thank you again for coming all the way from Texas to put this show on for us. So without further ado, I will hand it back to you, Mila. Thank you.
Thank you so much, Dr. Butler. And I think you said something very important. We are unique. Maybe we think, oh, here in the U.S. things are different, but you can see by my accent that I'm from Brazil. I'm not from the U.S., right? But we have a lot of background. All of us work all around the world. I was yesterday at a ASCCP meeting. We met with many of the institutions together. And I think we are just one trying to eliminate cervical cancer, but it's a huge thing that we need to do, but we need to start. We should not wait for someone. We should be here today just starting to work together in the same direction. So we have some background. We work in Africa. We work in South America. Just ask anything you want, and we are all trying to do the best thing for the patients in the region that we are. So with the equipment that we have, with what we have available, and with the resources that we have in our countries. So this is very important. If you see something and you say, oh, in my country is different, I don't have this or I don't have that, just ask, because we might have some ideas and we can even learn from your experience as well. So we'll have the pleasure to call Melissa. She'll describe a little bit about the cervical cancer, the WHO elimination plan for cervical cancer. And she is very knowledgeable. She works a lot in Latin America. So please take the advantage of Melissa.
Thank you. Okay, so this is the Rio Grande River, and it separates Texas from Mexico. And I just really love this picture because when you look at this, how beautiful it is, a lot of people are risking their lives to cross from one side to the other. And we work a lot in Texas in this border side that is very fluid. Patients go and come, go and come. And within the US, we can see a lot of disparities, and that's why I think it's so important for us to always think cervical cancer is always the disease of the underserved, wherever they are, right? Texas, the Caribbean, Africa, doesn't matter. Miami, exactly. Okay, so exactly, a lot. And it's usually for women that are in their prime of their lives. They are taking care of their little kids. They're probably a single mom, right? And they have to face this disease. So everybody knows Dr. Surhausen, and I think one of the most important medical discoveries of history is the associative link between HPV and cervical cancer. So we know now, today, that HPV is necessary but not sufficient, HPV infection, to cause cervical cancer. So number one, always keep that in mind. And of course, he won the Nobel Prize, but it was a team effort. And it was many, many years of research to get to that conclusion that HPV has an associative link with cervical cancer. The other thing to highlight here is that we have many opportunities for prevention of cervical cancer. So first, we can do primary prevention with HPV vaccine. So before the cervix has any kind of infection with HPV, any kind of contact with HPV, we can put the vaccine and prevent women from getting any kind of like abnormal disease. I wonder if I do this, if you can see that? No, okay. So then the other thing is that this word is a keyword here, persistent infection. Why? Because you can get an infection and then regress to clearance, okay? And so this stage here is something that we see. So everybody knows more than 80% of the population has at some point been exposed to HPV. but most of them will clear the infection, okay? So the other thing here is that this persistent infection can then progress to a lesion that would be a CIN 1, 2, or 3. So at this point is where we do secondary prevention with early detection. So whenever we look at these, do a PAP, do an HPV screening, VIA, this is what we're trying to detect. These abnormal lesions that are persist through persistent infection that will then progress to invasive cervical cancer. All of this time can be like about 15 to 20 years, and I think that's why it's so important to highlight many opportunities for providers to have encounters with these patients and make sure that we have the appropriate tools to be able to treat them before it becomes invasive cancer. But unfortunately, in 2020, more than 341,000 women died globally from cervical cancer. And as we saw before, or discussed before a little bit, you can see that there's disparities in the distribution of cervical cancer. So it matters where you're at, it matters where you live, which community you belong to, and the highest burden occurs in low-resource settings. So 80% of cervical cancer cases are in low-resource settings, unfortunately. Most of the disease is here in Africa, but you can also see here disparities in our regions. And so like you can see here, the US has very low rates, but if you focus on the different states, then you can also see disparities in the states. And we talked about, Florida, Texas, they have higher incidence rates of cervical cancer, unfortunately. And then if we scope here into Texas, that's where we live, there's also disparities within the state. And I told you guys we work in the Texas-Mexico border, where the incidence and mortality rates of cervical cancer are much higher in comparison to the rest of the state, in comparison to our country. And so just to describe the population a little bit for you, 91% of the population is Hispanic, a third of the population is uninsured or live beyond below the poverty level. And so the communities that are being taken care of by federally qualified health centers are always very low resourced. So, so just to kind of like capture here, we have a disease that is caused by an infection. We have many opportunities for primary and secondary prevention, and it is the disease of the underserved. And we talked about the importance of doing this because women are at the center of their families. So that's why the world united against cervical cancer. And so it's so important for us to keep that in mind and always try to put a picture and paint it for people to let them know this is just not a number. It's the women. It's our women. So in 2018, the WHO director, Dr. Tedros, released this call for action for the world to get together against cervical cancer. And then with that, in 2020, an elimination strategy came up and it was accepted by the World Health Assembly, by the WHO. And so you can see that it has 3 pillars. So we are aiming, or our goal is to vaccinate 90% of girls by the age of 15 years with the HPV vaccine, to be able to screen at least 70% of women between 35 years of age, and then second time by 45 years of age. And then this one is the one that we think is where we need to focus more, is that 90% of women identified with pre-invasive disease or with cervical cancer would get care, appropriate treatment, which I think is so important for you guys to be here and be training here so that we can reach that target by 2030. So here's just a picture showing kind of like the advancement and the progression. The countries are getting behind this. The communities are getting behind this. I think it's kind of like easy to make the case, right? We have the tools. We just need to get there. And so more and more attention is being paid to this. Bill Gates Foundation just gave a lot of money for elimination of cervical cancer, mostly going to be focused on HPV vaccination, but I think it's a great opportunity for us to have traction and progress on this. And Mila just said it before, this is why we have to do this today, because the goal is to reach these 3 goals by 2030, and it's already 2024. So how will we get there? We need policy, we need very strong policy. we need for an elimination, cervical cancer elimination plan to be embedded within the national cancer control plans. PAHO is making a big push to help countries do this. If you're interested, if you don't have an elimination plan, let PAHO know, because we are helping communities in Latin America do this already. So let us know if you guys want support in this area in the Caribbean. The other part, of course, is we need more HPV vaccination. We know that the stronger implementation strategy is to do this in the school setting. And if not, and if, for example, in the US, we don't have that in the school setting universally, but we know that the second most important thing is for providers to recommend it. In terms of screening, to have affordable HPV tests, and a lot of people are working on this because, unfortunately, good HPV screening in the national setting is not cheap. But it's, at the end of the day, is cheaper than cytology, so it's a good investment for the countries. And then navigation. So here, I wanted to change this slide because it says here navigation. Every patient with abnormal results need follow-up. But actually, I would say navigation starts at the time we reach the community. So educate the women, make sure they know that they need to be screened, make sure that they know that their kids need to be vaccinated, and then follow them through so that they can get the care that they need. Of course, make sure that we have treatments with all the tools that we need, and we included here doctors, nurses, PIs, anybody, and make sure that we have appropriate tools and training for cancer care, radiation therapy with brachytherapy, etc. Good advocacy, and a lot of groups are getting together behind this, and research. And research also includes implementation research. So the last slide I'm going to show you here is because sometimes as public health practitioners, we think, okay, how can we make the best use of our funds, of our money? So elimination, I forgot to tell you, we'll reach elimination when we reach this threshold here, which is 4 cases per 100,000. So we are not aiming to eradication like they're doing with other diseases. We're aiming to elimination of cervical cancer as a public health problem, which will be 4 new cases per 100,000. So if we see here this line, this would be the status quo, and then the green one would be with vaccination scale up. So if we look at this line here, we would potentially reach elimination sometime between 2039 and 2044. But if we focus on screenage and reaching the scale up coverage, we would reach elimination by 2029. And then screening scale up by itself would be, yeah, so very important that we continue to focus on having women be screened appropriately, and of course follow up. And with that, I want to finish here, and thank you all so much for your attention.
We'll talk a little bit, and we saw how important it is to continue screening and doing the secondary prevention. We'll have many patients still and many generations that we still need to do secondary prevention. Just one thing, in the cover that Melissa showed us, a lady with children, I learned this week, only this week, that lady is a cervical cancer survivor from Kenya. She was stage 4, and her kid was the first one to receive vaccination in the country. So I like even more that picture now. Okay, so let's talk about screening, and I would just say what we have worldwide. It's not in my country, but okay, this we have everywhere. Melissa talked about inequity and a little bit about cervical cancer. I don't need to talk again. And unfortunately, we know that more than 90% of the incidence of cervical cancer happens in low and middle income countries, and also I'll just go through all this because Melissa talked already. So when we learn about the HPV, we can understand what we need to do to screen and what we can do to treat these patients. She taught us that the transient HPV infection, it's okay. The individual will recover and will just clean by itself the infection, but when it persists is the problem. And here we have to understand the balance between the increase in exposure of the HPV that we have for many people. Now, of course, with the vaccine, this is a little better. But also, in some occasions, we have the reducibility to clean ourselves or to do the clearance in our bodies. And this happens, of course, when we have immunosuppression. So when the population of HIV is higher, is not in the Caribbean, but in many parts of the world that we work, especially in Africa, this happen. But also for the patients with organ transplants or any other kinds of immunosuppression, we need to pay attention because these patients, they'll have less ability to to do the clearance of the virus, and also the progression will be fast. So what we have today as the current methods for screening all over around the world. The cervical cytology, or the PEP test, it's very old right now. We have this for many years, and we need to say thank you to Dr. Papanicolaou, because for many years we couldn't find something else better than the cytology. We have two kinds of cytology. I don't know if you can see my mouse, but the liquid cytology and the conventional cytology that we do in the slides. I don't know what you usually do in the Caribbean. You have both? Yeah. So the idea for the liquid-based cytology is just because it's less, the opportunities to have a bad, an unsatisfactory sample, it's less. But also it's much more expensive. Of course, it's more objective because the computer will read, but it's much more expensive. So many countries we cannot use. In Brazil, we have very few places that we can use the liquid cytology. We use basically the slide cytology. And in Africa, we just have the slide one. The liquid one is very rare. But for both, just what happened is, for both, the sensitivity is very low. So what we do is when we use cytology as a screening, we use this more often. Because if we do the cytology again and again, the sensitivity will at least raise a little bit more, right? So this is the most important problem with the cytology, is the sensitivity. And the other problem when we use the slides is because we need someone to read. So we need a cytologist, or we need a pathologist to read the slides. And in many countries, we don't have this available, largely available, or widely available. To have a screening test, the importance of the screening test is when the patient is asymptomatic. So if I see a lesion, there's no reason for me to do a cytology anymore. If there's a lesion that I think it's cancer, I should just go ahead and do a biopsy. So we always need to think and remember that a screening test is for asymptomatic patients. And these are all the results that we can get with the cytology. You know all about this. But it's just to remember, to remind all of us everything that we have about cytology. And what is the second kind of screening that we have now around the world? It's VIA, visual inspection with acetic acid. Who has VIA in your countries? You use VIA in your countries, or you don't use VIA? No, nobody? You use some, yeah. There are many countries worldwide that we still use VIA, and VIA is just to put acetic acid in the cervix, wait 30 seconds, 1 minute, whatever is the guidelines in your country, and look with our eyes, our naked eyes, without a colposcope, without anything, any magnification. And then what happens is it turns white, and we can see with our eyes. This is super appealing, let's say, because it's cheap. It's super easy to do. I just need one person to read and the acetic acid, vinegar. It's cheap. But we need a very well-trained personnel doing it. If not, it just doesn't make sense to do it. Because what happened with the VIA, and we have trainings for nurses and providers in the primary healthcare facility in many countries, and the training should be, don't miss cancer. This is the idea for the VIA, and I always say what makes me feel good with the VIA is that I know the provider is looking the cervix, because we need to put a speculum on and we need to look the cervix. But we need to practice and train our eyes with the lesions. And what we have been seeing all over is that it's very poor, the quality of the personnel doing VIA. So we need to train. We need you to train everybody in the countries that they use VIA. So this, I always say something before the slides, but this is what I was saying, that we just use the vinegar and we need our eyes to see the white lesions in the VIA. So positive VIA seems very simple, but sometimes it's not that simple because we need trained personnel to find the lesions. So it's super attractive. It's low cost, low tech, very easy, and we just go there and we're supposed to see it. But there are a lot of challenges. The quality control for VIA, it's very hard. And I'm saying because we work a lot in Mozambique. I'm one of the international mentors for Mozambique from IGCS. We work for 10 years there. And we see how poor is the quality. It's very hard to do quality control, but the quality of personnel doing VIA. So we need you to help us train everybody. And the last method that we have for screening is the HPV testing that you all know. And if the cytology is very subjective, the HPV test is objective. So it helps us because the computer will tell us the result, right? So it's high, the sensitivity is high. And what is very important for us to understand for the HPV test is that the strong negativity, the predictive value for the negativity is the best part. So if I say the patient is negative for HPV, I know the risk for this patient to have cervical cancer in 5 years is very low. But there are a lot of challenges. Of course, HPV tests still very expensive. It's hard to train personnel again for the majority of the tests. We have many platforms that we can use, and I'll show you 2 of the platforms that we used to have in all these countries. And the PCR is very expensive. So we need to find other platforms, other ways to do the HPV test in all over so we can expand the use of the HPV. There's some groups, and Rice University that work with us is one of the groups that are developing the point of care HPV test. This one from Rice, they're almost there. It's less than an hour, what is great, and it would save so much lives. It will access people that we can never access, right? So this is the importance of the HPV test. And the other thing that is very special for HPV test is that we can do self-sampling. In the US, it's not approved yet, almost there, by the door. Hopefully we can tell you very soon that it will be approved here, but it's approved in many other countries. And the self-sampling, the good thing is that we can access people that we usually don't access, and we can do this with the HPV test. So the ideal test in low and middle income countries is an easy test, acceptable by the woman, not expensive, with high sensitivity, and of course rapid results. These are 2 that we have experience with. The CARE HPV we used first in Mozambique. It's super attractive as well because it seems it's very cheap, but we need to run 90 tests together to be cheap. If I run 10, then it's super expensive, because every batch that we run, it's for 90 samples. And you need to train the lab personnel. It's not easy to train lab personnel to use the CARE HPV. But many countries have, and Rachel has this experience in El Salvador, they use CARE HPV as well. We used in Mozambique from the first time we started HPV there. And then there's I have no disclosure, nothing with the companies, so I can really talk about it. But the GeneXpert is the one that we have been using now. You can run one by one of the tests. It's expensive for low and middle income countries. We have nowadays a kind of $15, sometimes $18 each test. For the other one, we can achieve 5, but 5 if we run 90 together. And this is the same machine for TB. For who doesn't know, we just need to change the cartridges. The self-testing, I talked to you already. And what is this? This is a very nice idea from ASCO, and WHO goes with it, with the same idea. What ASCO did, if you don't know this paper, I can send to Susan and she can share with everybody. There's a group that worked a lot on this. This is the second edition already. And they divided the countries in the world in 4 categories, 4 layers, with a lot of resources, with nothing resources, and in between. And they tell us how we should run screening and how we should treat these patients based on the resources that we have, what is amazing. It's really good, with a lot of experts that we all know. But the most important thing is that this yellow thing that I highlighted here and I put there is that they say for any kind of resources that we have, if we have high resources or very low resources, we should use HPV tests instead of anything else. Of course, they know that many countries use VIA and they cannot switch very quickly, but they ask us to work on it and change. For the countries that use cytology, Brazil, for example, we use cytology. What they say is, if it's very organized, if you achieve many people and it's organized already, you don't need to change, but as soon as possible. Now Brazil approved HPV for the national system, thankfully, after all. But I don't know when they will implement, right? But they approved at least. So this is a graphic. I think Melissa talked a lot about this. We don't need to go through, but thank you for being here and thank you for spending your time learning this, because we are the ones that will create changes in the world, and we really thank your special skills and special time that we know it's super hard today, but thank you for coming here. This is Dr. Ida Ismail Prat. Then many of you saw the videos for IGCS, so we just thank her as well. Many of you saw these concepts in the phase 1 and phase 2 of the IGCS program. We'll just go very quickly to remember, like everybody, some topics in colposcopy. And why colposcopy is important? Because first we'll teach and learn together how to find lesions and to teach others. And many patients still will need colposcopy for when we do a biopsy and when we are trying to identify lesions if we can. So what's the objective of the colposcopy? Is to detect all the lesions that we can see in the cervix. And we should map all the lesions. So if I see one lesion here, but I see one lesion here, I should map all over and understand all the lesions that I have in the cervix, not only one. And the colposcopy will guide us. Oh, I think I was not talking on the microphone. Sorry. You just tell me if I need to put closer. Now I can hear, right? And this is just for the recording. I'm sorry that I need to speak on the microphone. But and this guide biopsies, but also to guide our treatment. How we'll do the treatment, how we'll plan our treatment. How we perform, we need the liquids, we need acetic acid, and we should have all the material ready. And we said this many times during the program, to be ready before the patient comes. We look all the material that we need, we prepare the room, everything, then we call the patient. And we need experience. It's not easy to find the lesions and to do colposcopy. So what I will say is practice. Today we'll practice a little bit with images, but we should keep practicing to keep our eyes ready for colposcopy and to find lesions. This is the colposcope. We have a lot of kinds, you know, all this, that we can stick in the bed or we can run with it. But there's some mobile colposcopes. Again, I have nothing with these companies, but we use a lot in our studies, we use a lot in our trainings and with our patients. And you see 2 types of mobile colposcopes today that you can start working on it. They are cheaper and they are just easy to go everywhere when we have less access. For the acetic acid, what happened is the acetic acid will change the protein when we have in the cervix, when we have lesions. The cells with a lot of protein will have less cytoplasm, more nuclei, and then the cells will become white with the white, with the acetic acid. For the Lugo is the opposite. Everywhere where it's black, it's normal. Everywhere when we cannot stain, then we'll have the lugo negative, then is the lesion or the endocervical canal. So we use the colposcope to be sure if this is a lesion or if this is a glandular disease or a glandular tissue. For the green filter, and we have these green filters in the mobile colposcopes too, you can practice in both, is to be able to see the vessels in the cervix. And usually we see vessels, and they are, if they are normal, they are like branches in the tree. They start very thick and they are going to be thinner and thinner. And this is a regular vasculature that we can see in the cervix. But if we see an abnormal vessel, how they look like they are curly, or they start anywhere, they stop anywhere. They don't have this branching, kind of the same as the trees, right? So we have this, sometimes we have blood stuck somewhere, but also these small vessels that we see totally different and thick and curly, they are different vessels, they're normal vessels. And here we can see again the lakes of blood, and then these small vessels that they start anywhere, they stop. Don't advising us that they'll be thinner and thinner, and we call this abnormal vasculature. And it's easier to see with the green light. But I need to say, we talk about a lot about the green light, but we should always look for with the white light. And I'm saying this because I saw so many things, but I went to a clinic and they said, oh, we had a course and they taught us to see with the green light. So they were only using the green light. What is much harder to see the lesion? We can see the vessels, but not the lesion. So we should start with the white light. Again, this is all the material that we'll need. When we do a colposcopy, we'll look the cervix, but we cannot forget the vaginal walls. And it's very hard to find lesions in the vaginal walls, but we need to look and think about it. Then we can find them a little better. The squamous columnar junction. We always should find the squamous columnar junction, and this is just the junction about the two tissues. I'm just recapping everything we saw in the program, but inside we have columnar tissue or the endocervical tissue, and the ectocervix is squamous tissue. The line that makes both get together, this is the squamous columnar junction. Why we always talk about this, why this is so important? Because the great majority of the lesions, cervical cancer or pre-invasive, they'll start around the junction. So we should always see the junction. Oh, but sometimes we cannot because the patient is a little older, and when it's postmenopausal, this will be inside the canal. It's okay, but we should describe that we haven't seen. And we need to see the entire squamous columnar junction. Why? Because if I cannot see one piece, maybe there's a lesion inside the canal and I'm not seeing the lesion. So we should pay attention. This is one very easy, right? Here's the endocervical tissue or the columnar. Here's the squamous, and the line that get them together, that they join each other, this is the squamous columnar junction. So when we do a colposcopy, it's not enough if we see the outside and we find the lesion, the white lesion is there. I don't have a pointer, but the white lesion is there. But we need to look inside, because look these two images. Of course, this is a fancy endocervical speculum that we don't have everywhere, but we can use anything. We can use our instruments, regular instruments that we have. Thank you. And here, if we didn't open, we'll miss this lesion. And this one the same. If we didn't open, we'll miss this lesion inside the canal. So we should always open and look inside the canal. And how about the glandular epithelium? We should look also. And when we have lesions in the glandular epithelium, it's always worse. They progress fast. They usually are worse than what we think. And the bad thing for the glandular epithelium is not like feature, we don't see the features as we see in the squamous. I cannot say, oh, this is a low-grade lesion, this is a high-grade lesion. It's always something that we need to pay attention when the lesion is inside the canal. So some normal findings in the colposcopy. but in a special population. And the first special population I'll say for colposcopy is a pregnant woman. It's very hard to do colposcopy in pregnant women. So call someone, call your friends, call your colleagues, call us, take pictures if the patient agrees, and discuss with somebody. Because when we looked, we think, oh, this is cancer. But it's not. Usually the pregnant woman, there are a lot of vessels. There's some edema in the glandular, in all the glandular tissue. It's very hard to see. The menopausal we talked already. We cannot see the majority of them. We cannot see the junction. It's inside the canal. And it's okay, we just describe it. But there's some colposcopic findings that are benign, but we also need to practice and train our eyes. And the first one is condyloma, and everybody would say, oh, this is super easy. But it's not so easy. Sometimes it's not exactly super common like we see these condylomas. And we need to pay attention because it's rare, but we have some cancer in the condyloma and even dysplasia. So we should also use the acetic acid to see, and if we have dysplasia, then we treat as CIN. This is another condyloma, very easy for us to see because this is super magnified. It's from an atlas, and here this one is very white. Then abortion cyst, it's a very benign lesion that we can see in the cervix. This is, I used to say, is a ball of secretion. When we have the glandulars open, they have a lot of secretion going out, but when the metaplasia comes and covers everything, they still put some secretion there, and they'll finalize with this little ball, totally benign. It's a ball of secretion, that's it. But this image is very interesting for us to understand. We usually can see one vessel in front of the Nabotian cyst, and we usually see one. But sometimes there are a lot of them together, and we don't know what it is. And even for experienced colposcopists, sometimes this is tricky. And I'll tell you, we were in Mozambique last week, and we are running a new study, and we saw a patient, and we said together, my mentor, Kathleen Schmaler, and myself, oh, this is cancer. And we biopsied, and it seems now, after we biopsied, it seems it was an Nabotian cyst, but like a lot of them, super not an easy image, and we both were thinking, oh, maybe this is cancer. What should we do now? And then we need to do biopsies for all these patients for this study. So we did a biopsy, and it seems it was not cancer, it was an Nabotian cyst. So sometimes it's tricky. And if you see this image, it was not like this, it was a kind of different, but this is a kind of tricky. When we look, we say, what is this? But this is more like the common one that we can see, right? And the polyps are the same. Oh, no, this is so easy. I know what is a polyp. Yeah, we know when it comes like this. This one, we even are not sure if it's a polyp or if it's a myoma that is coming out. But this one, look, this is also a polyp, but a huge polyp coming out from the cervix and with dysplasia. So we should put acetic acid even in the polyps and see if there's dysplasia. Sometimes it happens. So CIN, what we need for CIN is, of course, we can always see the difference with many features from the low grade and the high grade. The high grade is the real pre-cancer that we should treat. The low grade, we all know that the majority of them, they'll clear and they'll go away, then we don't need to treat. But in some countries, they need to treat because the patient will never come back. So now in Mozambique, after 10 years, we are starting to look these lesions, but we treated for many years. Because they always say, and they have a very high prevalence of HIV, what makes a lot of difference. It's 20% in the big cities. It's really a lot. But we usually don't need to treat. Let's just recap, very easy. Normal, this is the epithelium for the cervix. Normal epithelium, the basement membrane will be there, very intact. The HPV loves the basal cells. So the HPV will come here in this part and will damage these cells first. And this is just some mild changes, and we call this CIN1. When we have more cells in the epithelium that changed because of the HPV, and it goes to 2/3, we call CIN2. And if we have the whole epithelium, we'll call CIN3. Oh, but how about the carcinoma insider that I always learned? The carcinoma insider, the basement membrane will still be intact. So it's not cancer, it's not invasive, it's pre-invasive. But the problem is for people that works with the field, it's super easy. But for people that don't have too much experience, this makes us stress. Oh, but this is carcinoma, and I'll treat as cancer. And I saw this many times, not once, not 10 times, many times in many countries. People stress because of the carcinoma insider. So what we are trying to do as societies and as experts and colleagues is to try to don't say carcinoma insider anymore and just say CIN3. They are the same. So I always say that we need to be your best pathologist, if we have one, right? So we should talk to our pathologists, and this is what we did in Mozambique. We talked to the pathologist and said, can you just don't use these words, because it's super hard for us to teach the clinicians this is not cancer. So as much as we can. And of course, when it erupts the basement membrane, is invasive cancer. So low-grade lesions and high-grade lesions, we can differentiate them very well. For I didn't show you the low grade because we were discussing other things. But for the low grade lesion, usually in the colposcopy, we see this map, like geographic borders. The white is not so white. It's very transparent, and we can see. And there are a lot of lesions everywhere. And we cannot see exactly the borders between the lesion and the regular cervix, like this one. It's a low grade lesion. This one too, there are a lot of, we call satellite lesions when we see, it's like we put we paint the cervix and we can see a lot of these small lesions. And the high grade lesion is the opposite. The white is very white, it's chalk white, and the border is very like sharp. We can see exactly, if I ask her to draw here, she can draw exactly where the lesion finish and where the normal tissue comes. Again, high-grade lesion, very sharp, very dark, the white, it's very chalk, and it seems it's out from the cervix. And of course, if we have a beautiful colposcope, we can see a lot of features as the mosaicism, the punctation, and the white areas. But many times we don't have these beautiful colposcopes. Today we can practice with both, with the small mobile colposcope and with the traditional one. The way we describe the findings, we should describe if we are seeing acetowhite, mosaicism, punctation, abnormal vessels, or anything that it's a risk for cervical cancer. Again, the junction we should see, and what we say is if it's satisfactory or unsatisfactory, if we see the entire squamous columnar junction. This we saw. The way we'll describe the colposcopy, if we see the acetowhite epithelium, here we can see the lesion very all over around the cervix. The mosaicism that I showed before. Here we can see these little squares like a honeycomb. This is a very unique pattern for high grade. Let's see, here we can see this honeycomb and this small squares, right? This is mosaicism. Again, here we see an abnormal vessel and the mosaicism up here. Here we can also see. The punctation is also when we see all this vessel, the damage. This is also all vessels that are damaged. These punctations, when they have different sizes and different structure, we can see that this is usually high grade. Punctation, again, we can see they are all different sizes and all the damage in everywhere in these vessels. This is high grade lesion. Again, the same here. I know you saw all this before, so I'm just going a little quicker. And the leukoplakia is when we see the lesion with our naked eyes. We don't put a colposcope, we put the speculum in the patient and we see the lesion. And we should always biopsy because we never know what is behind. We cannot see the vasculature very well, and we don't know what's behind this, so we do biopsies. It's not going. We are almost there. We saw the abnormal vessels. So low grade, very transparent with a lot of like a geographic borders, and high grade, very sharp, very dark, the white, very different one from the other one. And the lab abnormality, this is the one that I say we all feel stressed, right? We can see that we saw before many glandulars, they were very like light pink. But this one is a disease in the gland. Consider we put acetic acid and it's all white. When we should think these can be invasive, when we should just go ahead and biopsy the patient, the lesion. When we have ulcerations, necrosis, the atypical vessels, here we can see very well they are all curly and coming from everywhere. When it's easily bleeding with these chalky white lesions that we saw before. There are a lot of limitations, but for me, the most important limitation for a colposcopy is that when we don't have experience, so we should continue practicing. And of course, we need to see the squamous columnar junction. How to put it all together? Just remember when there's abnormal screening tests, when we need to do a colposcopy and we have this available, we should recognize the patterns that we have in the colposcopy and take biopsies and ECC every time that is necessary. Okay, this is some of our courses all over. And this is a picture in the Caribbean, because we were all in Antigua with Pajo. So we need to take a picture together. We can put in the next talk. We don't need to. It's okay.
That's that. Okay, so this we've talked about already. That's almost 600,000 cases. More than half of women with the dye. The burden is mostly in low resource settings throughout the world. And it is a completely preventable disease. And we have the tools to eliminate this disease, as Melissa was saying earlier, and we have 6 years to do it. Thank you, Dr. Tedros. Here are the options for precancerous lesions. We are going to be talking, we won't be talking about laser today or HIST, but we will be touching upon the other ones in that list. All right, and as Melissa said, I think I like Melissa's slide better. I might have to steal that from you, Melissa. But it is saying the same thing, exposure. A lot of times, instead of progression, it gets to clearance, which is why we don't typically screen young women with HPV in this country before 30, because lots of times it regresses. What we're worried about is persistence, which can then lead to progression, which I think most of you already know. Okay, so surgery to the left, LEAP, LETS, CKC, laser, ablation methods to the right, cryo, which is cold, thermal, which is hot. We're going to talk about these things now. Okay, so the WHO recommendations for excision ablation, when LEAP or LETS is available, that is what is preferred. Excision is recommended when you think the lesion is 75% of the cervix or more, greater than 75, or it goes beyond the tip of the cryotherapy probe. We're going to talk a little bit about how that differs with thermal ablation. We want to make sure that we don't ablate things that go up into the canal. So if it goes up into the canal, that's maybe a reason to do a LEAP to try and see margins up inside. And then if there's a recurrence after treatment, we don't cryo and then have a recurrence and cryo again if we have the capacity to do a LEAP. Many places don't always have that. So again, as Mila has mentioned so many times, we have to work in the context in which we're working, obviously, and what's available there. Cryo and thermal is recommended over no treatment. These are really hard to see, but basically it's just saying LEAP, LETS first, cryo good, non-MDs can do ablation. Cryothermal ablation is also recommended, but these are all available on the WHO website, and you can look to see what the recommendations are. They're impossible to read. I know you guys all took the course, and we just did a training in Belize, and the IGCS course, when we asked for feedback at the end of the Belize talk, everyone was like, oh my gosh, it was such a bear. It was crazy, it was so long, but across the board, and I don't know, I don't want to put words in anyone here's mouth, but across the board, we said, well, and then what'd you think of it? They're like, they said, you know what? It was really worthwhile, because it was like, I've been doing this for years. There were a lot of gynecologists in that training. It's like, and I learned a ton. And I learned a ton when I took that course. I was like, I get it. I know what you mean. So it really is just about talking the same language. And here is, this is what's used worldwide, the transformation zone, the TZs, type 1, type 2, and type 3. ASCCP uses different language, which can be confusing, but when we work around the world, people refer to transformation zones where the transformation is completely ectocervical, and you can see exactly, I think I have a picture here, yeah. Completely ectocervical. Type 2 is when it goes up inside the canal, but you can still see the superior margin of that. And type 3 goes up so far into the canal that you cannot see the superior margin. So type 1, type 2, and type 3, and just so that we're all on the same page about the vocabulary and the language that we're speaking. Okay. So here we're going to talk about this cold knife cone. There are good things we've talked about during Mila's talk about CKC. We have good margins. It's a big piece of tissue. It gets sent to the pathology. You can tag it so you know where 12 o'clock is. You can see where all of those things that we all know, right? The downsides, it requires all of these things, a scalpel, anesthesia, an operating theater, all these things, which in many places is really just not feasible. How you do it, has anyone done a CKC here? Yeah, okay, so you all, I have too, I haven't in a long time, but this is, you have to get good visualization, you need to have analgesia, so with some lidocaine, get your tissue planes, grab the piece of tissue. There is number 11 blade, you need to really, it looks like, it's called a cone because it looks like an ice cream cone when it comes out. And then what to do with the surgical bed, whether you spot hemostasis with a cautery. The Sturmdorf sutures were mentioned by you, which is really almost historic at this point. So we can talk more about that in detail to whomever has a specific interest in CKC. This is for you guys who are already taught cold knife cone. Teaching your residents is important, but teaching the non-physician providers is probably not going to be the best bang for your buck. The loop, these are all of the different things. I can tell you that in the places I work around the world, we have one of those loops available. So just so, and it varies which loop we have that day. It uses electricity, it has a monopolar energy. You just need to make sure you're using an insulated speculum. You need to make sure the patient is grounded. You use local analgesia, or you do them in operating theaters, depending on, but the bonus is you really can't do a cold knife cone in an office-based setting, whereas you can do a LEAP much more easily in an office-based setting. And so there is, as we discussed, there is some cautery on the margins that can sometimes make the pathologist crazy, but in experienced hands and with like a single swipe, many times the margins are very clear, and the pathologists are fine with it. Try and do it in as one piece if we can, but sometimes the lesions are too big. So how do you treat this? We see the whole thing, but many of the loops are not going to be big enough for, we're going to need to do 2 swipes of that. So there is some infection problems. We talk about stenosis and bleeding, some obstetrical complications following a LEAP, including preterm birth, rupture of membranes, choreo, low birth weight, and this is increased risk of preterm delivery depending on how deep you go in your LEAP. A top hat is, if you have concerns about the canal, going in with a top hat can take the place of a cone so that you can get the tissue you need to get and make sure that you see what kind of disease is inside the canal. Okay. If we're not doing surgery or excision, then we are off to the right-hand side of this slide, which is ablation. We're going to talk a little bit about cryotherapy. In many settings, additional testing is really not easy, so there's a see and treat, whether it's VIA, and if positive and not suspicious for cancer, treat. Or whether it's HPV testing, which I hope is coming down the line in more places, which we have, as we discussed earlier, some low-cost testing that hopefully will become more widely available soon. But when we have to wait for either a pap smear, which requires a cytologist, or biopsies, which requires a pathologist, oftentimes the or not available at all, or the quality is low. I just came from, and there were, it's a country of almost 12 million people, and there were 5 pathologists in the entire country. So sometimes, it's just not feasible to rely on pathologists. And that was not for GYN, that was for everything, all of the pathology for 12 million people. Also, when you come back and forth, see and treat, we tend to have a much lower loss to follow-up. And you can imagine the way we do things in this country, where you get a pap smear with co-testing, it's positive, you have them come back, they get a colposcopy, you take biopsies, you get the biopsy results, you have them come back, it's positive, you schedule their LEAP, you have them come back, you wait for their, think about that in a low resource setting. Impossible, you cannot do it, right? And the loss to follow up for that is hard. And most of the time, the burden of cost is on the patient themselves. They have to pay for each and every one of those steps, and so it's just really not a feasible modality in terms of trying to really affect cervical cancer, lower the cervical cancer rates in the country. All right, so let's just talk a little bit about cryo. Advantages: doesn't require anesthesia, doesn't require electricity, can be performed by many different skill levels of providers. Side effects are rare, complications are rare, and side effects are well tolerated. This is what we need to do. We need to make sure, like always, that we see the entire squamocolumnar junction. We want to make sure the lesion is less than 3/4 of the cervix. Some of that is because the larger the lesion, the more suspicious it is for cancer. So we never ablate cancer, as we know. They need additional or different kinds of treatment. So you need to have a cryoprobe that's big enough to cover the entire lesion when you're doing cryotherapy. No suspicion of invasion or glandular disease, not a TZ3, and you need to see if they can follow up. That's the force being with me. All right, this is what we need. I think you've all seen a cryotherapy gown and tank, different probe types. This is the equipment we need. Similar to any treatment, you need the place for the patient to be able to lie down. I have done these on with sticking a bunch of towels under someone's bottom, on a low stool, almost close to the ground with a headlamp on. I mean, you can do these in very low resource settings as needed. You do need a speculum still. You need the cryotherapy unit, and the big issue most places is you need that cryogen tank, whether it's N2O or CO2. And there are, here's some other things: gloves, swabs, vinegar, cleaning solutions, some kind of medical record form. The cryotherapy post-cryo is the picture you have there to the right. And the deeper the penetration of the freeze, the larger the ice ball. And it gets, cold, so right, -50 to -90 degrees Celsius, pretty cold. And when you see adequate freezing, means it's the margin of the ice ball extends 4 to 5 millimeters past the outer edge of the cryotip. And that's how you can tell that you've done a good freeze. You want to make sure that the woman's doing okay, not having a lot of cramping before she gets up. You want to advise her about what to do after. We say no sex, douching, nothing in the vagina. What do you guys advise? For how long? 6 weeks. This says 4. I mean, it's kind of a data-free zone, and I don't know how many people actually do it. If there is, you want to tell them also about the possibility of a watery-like discharge that can last for up to a month, because that can be scary if people don't realize that is a common side effect. But things to watch out for are fevers above 38C, really severe lower abdominal pain that doesn't go away with NSAIDs or Tylenol or whatever they're using, heavy bleeding for more than 2 days, or bleeding with large clots, or if they're concerned, and you schedule a follow-up appointment for them if they can make it. Cleaning, you wipe off the tubing. You never submerge the tips, because if they get wet inside, that's literal 20 minutes, so that and wiping down the tubing itself. The World Health Organization does recommend that women who have received ablation treatment should receive a follow-up in 1 year to just ensure that to make sure there's been no progression and that there has been cure or regression of disease. So this is particularly important in women living with HIV or who don't know their HIV status or who live in high HIV endemic areas. We want to make sure that particularly, we're going to talk, you do, yes, El Salvador, they do 6 months too. Yes, so I should say 6 to 12 months, yeah. And I should just say, actually, whatever the local standards are is when we should have them come back. Next slide. Okay. So success of cryo, anywhere, depending who you read, it can be 77 to 93%. There's about a 5% persistence of disease and about 20%, just under 20% possible recurrence within 6 to 37 months, which talks about why you might want to see them back in 6 months. Sorry. We talked, am I going the wrong, I'm going the wrong way. And now I'd like to start my talk again. No, okay. Okay, let's not do that. Okay, so let's talk about, this is my colleague Julio from El Salvador. Here is one of the reasons why cryotherapy is so difficult. These tanks are really heavy. A 5-foot tank, which is, me plus, I'm like 6 inches taller than that tank, but only treats about 10 to 20 people. So you have to, if you're doing a huge delegation, that's a lot of tanks. It's really, this is a big thing. Gas is really expensive, a lot of times just really not available. We were doing a big delegation in Haiti over a 5-week period. It was Tuesday. And I was like, okay, great, it looks like you're, at the time, I think it was VIA, actually. And I was like, this is years ago. And I was like, okay, it's positive, let's treat you. And they're like, we're out of gas. And the whole country was out of gas. There was no, so we were like on the phone with the Dominican Republic, like, let's do this like cross-border, we'll go to the border, we'll like get the clandestine gas. Anyway, what a mess. So it's expensive, it's hard to procure. The other thing is it's gas under pressure. So it should be standing up in a cool place, undisturbed prior to using it. I don't know how many, but a lot of times the places I go, it gets put in the back of a pickup truck, exposed to the heat, bouncing around, falls over, rolls up and down the truck of the back of the pickup, the bed of the pickup truck. And when we get it to wherever it goes, it's like, what happens when you shake a Coca-Cola can, right? And then you try and open it, and that actually happened to us once, and we're all very glad that I was doing a delegation and that we were trying to figure something out, and it literally exploded. I was like, I don't know if how we all could have died. Here, it's dangerous. So how do we deal with that? What are some alternatives? And what's come up is thermal ablation, which there are some real advantages. It was the WHO endorsed it in 2019. We've had someone who's worked actually with Ian Duncan, which is a huge thing. But it's all these trying to call it one thing. Everyone knows what we're talking about. I'm just gonna. Can you hear me? Okay, sorry about that. Should I try the other one? Better? Is this better? Okay. It's okay? All right. If it gets annoying again, just let me know. So this is the desktop YSAP coagulator. This is what we were talking about earlier. This is, yes, exactly. And so we have this desktop coagulator has been used in Scotland specifically, the UK, but specifically in Scotland with Ian Duncan, who really introduced it and trained a whole generation of people who in the UK. And this desktop device, we have talked to our migration in or out of Dundee. So they have published now up to 20 years of data with really good follow-up of women who've had thermal ablation with this desktop device. And the cure rates are, after 20 years, 96%. So that's, so I can give you that paper. Wendy Norman is like amazing. And was actually able to collate all of that data with her colleague Kalpana. Anyway, so we have some good rates, cure rates. Dolman showed some good cure rates of about 94%, but it is lower in low resource settings. So why is that? And some of it is, this is an electric machine, needs to be plugged in. So we actually, here are some of the handheld devices. We actually talked to the guy who makes the YSAP device and tried to convince him to make portable, put in your pocket. He came up with that one in the middle, the C3. Liger also has a device. We're working with the head of Liger to try and modify that device to make it more, to make it better for field work. So changing the probes, we've talked to YSAP about changing the probes, because the thing about the people in Scotland is they do a 2-probe approach. I was talking to you about this. Are you trained? Where they take an endocervical probe, a thin 5-millimeter probe that goes up into the distal endocervix, because we think you know about that? For these portable, yes, there's the probes that we're working to change those probes to have more choice of probes, both also not just the endocervical probe, but also the size of the flat probes and the size of the nipple probes, because the ones that are available now do not give us what we need in many cases, you know, for small little cervices or for really big. We need more choice in probes. So we're working with Liger about getting those different probes, and then we're going to test them out in the field. It's one of our projects. Anyway, so these thermal little ablation devices, Liger YSAP work on a battery, except the one in the middle can do 100 treatments before the battery needs to be recharged. I have not done that. I don't know if that's what they say. But it is really good. The battery for the Liger device is internal. The one for the YSAP device is external, but not having to rely on electricity like what you need for the desktop device, and not having gas under pressure, or for that matter, any kind of consumable. Like, you do not need a consumable except a rechargeable battery, right? But you can take this into the field. It weighs less than 2 pounds, I'm sorry. It's the size of like a curling iron. You can just stick that right in there. Side effects well tolerated. It's so much faster. Cryo, 3 minutes freeze, 5-minute thaw, 3-minute freeze. You have to wait in between. It's a long time with a speculum inside someone's vagina, right? This is usually, if the one treatment is about 2 minutes, less than 2 minutes. I'm going to show you a picture. All right, same kind of eligibility criteria. We do not ablate cancer, or never. You can't extend all the way up into the endocervical canal at TZ3, where you cannot see the superior margin. It cannot go onto the vaginal wall. That's also very suspicious. And if you have any suspicion of the lesion itself being cancer, so we talk about greater than 75%, with the flat, we can do overlapping around the whole lesion. We can actually, we don't need to cover it with just one probe tip. But one of the things we worry about is the larger the lesion, the more likely it may be to be cancer. So we need to just really think about whether you have any suspicion that this is cancer, or is this just a large CIN2+ lesion that is not cancer before you treat it. Because again, we do not ablate as far as we know, we do not ablate cancer. Sometimes we do when we don't realize it, but in places where we don't have diagnostics, we don't do this in pregnant people, or if they're 3 months postpartum, less than 3 months postpartum, or if they have active PID. Don't need much. Same sorts of things. They need a place to lie down so you can put a speculum inside. You need a light source, although some of these come with their own light source, but I always find having an additional light source is helpful. You need the thermal ablation unit, which includes the device, the probes, gloves, swabs, vinegar, cleaning equipment, some kind of record so that you know what you did and to whom. And this is an example of a thermal ablation, post-thermal ablation. There is good evidence of efficacy, but it's not prospective randomized trials. We are working on that right now. We actually just unblinded a study of 1,150 plus women, and we compared women with known CIN2 plus who were randomized to receive either standard cryotherapy with N2O, cryopen, which is gasless cryotherapy. I'm happy to talk to you, it's no longer available, or thermoablation, and both non-gas cryotherapy and thermoablation were non-inferior to the standard cryotherapy in terms of treatment, which is really exciting. So they all work well. We talked about 2 probes versus 1 probe. We're studying that. We're randomizing people to receive 2 probe approach versus a 1 probe approach. We also are going to try and get timings. Okay. Okay, here are some of the tips. The tip I'm talking about, you see, so the the nipple, flat, right? And there's an endocervical and even another endocervical. Sorry, I should hear. So there's the nipple, there's the flat. This is a little bit more of a nipple, and this is for the endocervical probe to try and get a little bit higher into that canal. And these are the Liger probes. This is the YSAP that we worked with Stefan, who's the engineer there, to get that done. And these are the Liger probes. So we're working to try and get, stand like this, the Liger probes to have more options, because there's a 16 millimeter flat, a 19 millimeter flat, and a 19 millimeter nipple. But those are not enough choices for many service disease around. Anyone who's used that, everyone's like, So we're working on that. Okay, so let's see if I can do this. Can you run that? There's the one on the left is actually a video. This is from Belize. We just did, the MOH of Belize asked us to come and do a training. It's a little bit of a raw video, but, and Dr. Torres, one of my colleagues in El Salvador, we were all doing a training for the providers in Belize. This is Liger, so this is a Liger device. Is there a volume on that? So you can hear the beep beeps. So there are ways actually to change the timing of this so that it goes to however many seconds you want. So we have it set at 10 seconds for each beep. This was a 40-second treatment, and each beep represented 10 seconds. So each time you hear a beep, 1 beep after 10 seconds, 2 beeps after 20, 3 beeps after 30, 4 beeps, and then it stops, and you leave it there after it's done, and then the light goes off. And once the light goes off, you'll see that in a few moments. Once the light goes off, you know that it is cool, and you can cool enough to remove and not. So that is now the end of the treatment. And you watch this, you can see it's about 10 seconds more. And when the light goes off, maybe that was the end of it. Sorry, it's hard for me to hear this. When the light goes off, you can remove it, and then you'll see a picture. And it looks similar to a therapy. It has a white, so that light just went off, as you can see. So they're going to extract the probe from inside, and you'll see that, sort of see, it's a little dark, but that's what the cervix looks like. We did do a depth of necrosis study, actually, comparing cryotherapy to thermal ablation on with who are getting hysterectomies for benign reasons, and who agreed to get a thermal ablation or a cryotherapy the night before their hysterectomy, and then the specimen was analyzed in the pathology lab to try and see depth of necrosis. We do not think, however, that this was a fascinating conversation with the pathologists. There were like 4 or 5 pathologists from around the U.S. talking on the phone, and there were about 12 different opinions. I was like, oh my goodness. Anyway, but the consensus was that with heat, we did time. Heat actually takes a while to spread and to affect tissues. So having sometimes it was less than 12 hours, depending on when it was done, it was less than 24 hours. So that it might not be representative truly of the depth of necrosis. That depth of necrosis may not be the best indicator for heat. So, no, yeah. Or, what it would look like a week from then. If we did that a week earlier or 2 weeks earlier, what would it look like? But in the end, it doesn't really matter. What matters is cure. So what we do is we treat them, have them come back in 6 months or 12 months. We do 12 months and repeat, in our research, repeat biopsies and try and make sure that there's cure. That whatever, if they known CIN2 plus when they came in, that has regressed and gone over. Okay, I gotta. In research, and if we can show that that's good, then we can talk about what would be when you see them back. Yes, but if you have a pathologist available and pathological, then yes, just to show that it has gone away, that you've treated disease and it hasn't recurred. Okay, overall cure rate really good. Persistence of disease, about 4%. Recurrence, about 13%. The papers are there. You can have this potential to treat lesions that are a little bit bigger by doing those overlapping applications. We talked about the battery. We talked about some of the limitations. Everyone has, we think we've settled on a temperature of 100 degrees Celsius, but duration of application, standardization of probes, and then single and multiple tips. These are all being under study right now, so stay tuned, and hopefully in the next little bit we'll be able to give you some more definitive information. Same sort of thing after this, make sure that women don't have excess cramping. There have been some vasovagal reactions reported, mostly when we were doing this in China, but it resolves spontaneously in almost all cases. So we do ask that they wait for 15 minutes just to make sure that they're not having any issues. And the same recommendations as we do for cryo for this. Cleaning the probe, you never submerge the probe, you never submerge the handle. You can use glutaraldehyde or Sidex for 20 minutes, soaking it up, up until not the end, but soaking it in that, and then you wipe down the handle with alcohol to make sure that that's clean. All right, so excision, preferred by the WHO when it's available, allows for a pathology specimen. You can check the margins, but you do need a highly trained provider, and there are increased complications when you do these versus cryothermal ablation, which are ablation methods, which are effective, inexpensive, easily portable, easy to perform, don't require anesthesia, don't require electricity, well tolerated by patients for the most part. Complications are rare, and will allow for a C a day, which will decrease loss to follow-up. So, sorry you guys, I think I went a little bit over, but I'm happy to take questions.
Now? Yeah, sorry. So just say again. It's always good to have an organized exam, so we always should say the same things in the same order, so the trainees will keep this in mind. The first question when we put a speculum on and we look the cervix, especially if we are doing VIA, is this suspicious for cancer? If this is, I'll go through this in a little bit. If this is suspicious for cancer and we are doing VIA and we don't have too much resources, then we need to refer the patient or call someone or do biopsies, right? But if it's not suspicious for cancer, we should continue. And the second question should be, can I see the entire squamous columnar junction? And why this is so important, Rachel was teaching us, because we need to see the whole junction to see if this patient is eligible for ablation. So if I see the entire squamous columnar junction, and the next question will be, can I see any lesions? Then we'll start thinking if this patient we can do ablation or if we should do a LEAP. So is this suspicious for cancer? What do you all think? No. Okay, let's continue. Can we see the entire squamous columnar junction? And here's a kind of tricky, right? Because we can see some glands here. We see a big lesion all over. And we can see the squamous columnar junction here. Okay. Can we see the entire lesion, or the lesion is going inside the canal? Type 1, we can see, right? We can see here the junction and here. If we don't see if it goes inside the canal, it's not ablation eligible, but this is not. So we can see a lesion. And then we start thinking about the features of the lesion to see if this is low grade or high grade. So we can see the color, what we think, and the borders, and if it's transparent or if the white is very white. I can see very well the difference in the lesion and the normal tissue here, but not very well here with some small lesions. Let's see this one. Is this suspicious for cancer? And maybe someone will say yes, and it's okay. Then what we'll do, if I think it's suspicious for cancer, but she does not think, I'll do my first biopsy here, and she'll probably continue, and then we'll see what's going on with her. But if I think it's suspicious for cancer, it's okay. I'll just do biopsy. If I think not, the majority said no, we'll continue. Can we see the entire squamous columnar junction? Yes, right? It's here. Sorry that I don't have a pointer, but it's here and all over here. Can we see a lesion? Yes. Where is the lesion? Here there's some lesion, and there, right? Some lesion. And now here we have the green light to see the vessels a little more. Anybody change opinion? Now you think it's cancer or not? No. Can we continue, right? Should we do ablation in this patient? Biopsy. And here is something that I always like to say. If we are not sure, we should not do ablation. We should do biopsy, see the patient back, call someone, discuss with a colleague, but we should not do ablation if we are not sure. I'm not sure we can do ablation here. Maybe it's cancer, maybe it's AIS, maybe it's something else. If I'm not comfortable, I should do biopsy. Or go ahead and do the leap. In many places, as Rachel was saying, we don't have too many pathologists to help us. And then we should just go ahead and do the leap, so we'll have a diagnosis and hopefully a treatment for the CIN 3 or 2, if this is what it happens. Okay? Okay, because what is going to change here if we do a leap straight? We'll have a diagnosis and we can treat the patient. So if we don't have available or if it's too expensive for the patient, we can do it in low resource settings. Of course, in the US, everything is different. We need to follow the guidelines for every country, and every country has different guidelines, right? But what I will say is the only thing is if this is cancer and we do a leap, it's just going to bleed a little more, right? But it's okay. We deal with the situation. Anything else? It seems high grade, right? It seems a honeycomb. It seems it's mosaicism, very irregular. All the little squares, they look different. And here we can see in the green light that there's some vessels that I don't like that much, right? Okay for this one? Leap. So we'll do a leap or biopsy. Yeah. Her question is where to biopsy. Very good question. Multiple. Let's say if it's a clock, which clock position do you biopsy? 12 o'clock, right? In this lesion. Maybe around the vessels that we saw here. I agree. And I'll do at least 2 biopsies. And this in the US, I know some of you follow ASCCP guidelines, some not, right? This is true? Is this true? Okay. So ASCCP is saying now that we should do at least 2 biopsies, maximum 4, right? And this is very important because they prove, we have a talk, we don't have time today, but in this study that they did, they asked experts to do biopsies in images, like all fake, right? But if they ask me, and I'll say a 12, but if they ask you, you say a 3. But if they ask me, you can do 2 biopsies, I'll do 12 and 3, and he'll do the same, 12 and 3, and we'll find the diagnosis. Improves the sensitivity for the diagnosis. Okay? Let's see one more. No, this is not the same. Is this the same? Yeah, the same. This one. What do you think about this one? This is an interesting one. Is this suspicious for cancer? No. Can we see the junction? The entire squamous columnar junction? I think I can. Let's see. Starting here, I come all the way here, and I come here. I think I can. Everybody agrees? Anybody don't agree? Doesn't agree. Sorry. my Portuguese is coming. Okay. So is there any lesion? Yes. In a clock position where you can see a lesion. Melissa, now you cannot say, you know this image. You're out of the game. Where we can see a lesion here. 2 o'clock. So this one, right? And 9. This one. Is there any other lesion? Oh, you saw our classes before. I'm just kidding. But there's little ones here, right? Satellite lesions. And I'll show one if I can, because I have this, I'm super tall, right? As you can see. But there's a lesion everywhere in the, at 12 o'clock and in the whole cervix. It's a shame that I don't have a pointer, but I'll show you here, and then you can see there. Here, you see a lesion here, going all the way, and it comes here. And it closes here. There it's easier to see instead of the green, but I just cannot go there. Now you can see? And this is why we need to train our eyes. Because sometimes we don't see in the beginning, but if we keep looking, we'll find the lesion. And this is what I'm saying about colposcopy. We should map everything, not only the most important lesion that we see. Now everybody can see the lesion there, right? Okay, this is tricky. Let's see one. Can I continue a little more? Okay, this we saw. Okay, this one, what do you think? Oh, this is a hard one because I cut the cervix, right? It's not the entire cervix. Let's see. Is this suspicious for cancer? Cancer. Not lesion, cancer. You think this is cancer? No, right? Doesn't seem cancer. So let's continue. Can we see the entire squamous columnar junction? Maybe if we have the patient with us and we open the cervix, maybe we can see, right? Because here in this one, I can see, but there no. I cannot see there, right? Okay. Can we see a lesion? Where? 12, right? The lesion is here. Can we do ablation? Why not? Perfect, because the lesion is going inside the canal. And when you are practicing with your trainees, you see that many people think low grade we can do ablation, high grade we should do a leap. And this is not in the criteria. The criteria is to do ablation, we need to, it cannot be suspicious for cancer. It cannot be it cannot be a glandular disease and going inside the canal. We need to see the entire squamous columnar junction and the entire lesion. That's it. And needs to be small enough for us to treat. Why we should not treat with ablation a lesion that covers almost the entire cervix? If it's not in the criteria anymore, because for cryotherapy, it should be less than 75, like a magic number, right? 74, we can do 76, we should not do. No, it's just because when the lesion is super big and it's covering the majority of the cervix, the risk is here. That's it. And the cryo we can use only once, right? So it needs to cover the entire lesion. Let's see one more. How about that one? Is this suspicious for cancer? Let's come here. Maybe? So if it's, yeah, you see some abnormal vessels, right? Around here. Here's the green light. We see punctation here. Very gross punctation, some mosaicism. And here is a kind of weird vessels, I agree. Can you, so many people will stop here and just do biopsies. Where you do biopsies? 6 o'clock, 12 o'clock. If we have 2 lesions or a big lesion in everywhere, we should do at least in 2 different places, right? Can we see the junction? The entire junction? Not really, right? But the lesion is going inside the canal. If we have only this part, we can see here the end of the lesion, but not here, right? Agree? Okay, let's continue. I know we are behind, but just a little more. This is the fun part. Okay, is this suspicious for cancer? Maybe, right? Yeah, it's the lesion is in the glandular. We can see the entire lesion, but it's a lot of vessels here, punctation here. So it seems we can see the entire lesion, but we should not do ablation in this patient. Do you all agree? Let's do biopsies and confirm that this is only high grade. Okay? You want more? This one, what do you think? Is this suspicious for cancer? No. Can we see the entire squamous columnar junction? No. Is there a lesion? Yes. It seems low grade or high grade? Low grade, right? Because it's very faint. It's like we put a painting in the cervix. We can see many satellite lesions. And can we do ablation? Why not? We cannot see inside the canal. Perfect. We cannot see the entire SCJ, and the lesion is going inside. Perfect. And we were right. It's CIN. This one is hard to see because it's just the green light. Let's go to the next one. This one. What do you think? Is this suspicious for cancer? No? Can the junction? Nah, no. Is there a lesion? And many people ask in the courses, like, if we cannot see the junction and the junction is inside the canal, so let's not do colposcopy. We should do, because many times there's lesion outside, and here we can see, right? A big lesion, exactly. A big lesion everywhere. Oh, the patient has low grade, but she did cryotherapy before. We cannot see the junction. The lesion, it seems, is going everywhere, so we should not do ablation. And this is another question that is common. If I do ablation and the patient comes back with high grade again, should we do ablation again? If we have criteria. Is if we have available LEAP machines, or if we can do CKC, we should do a cone after ablation if we have recurrence. If we don't have available, we are allowed to do another one. So we will always try to do LEAP and have specimen, right? Yep. Can you go back in the... Yes, yes, agree. Here. And again, we should always remember to look the vagina. Always. It's very hard to find lesions. It's rare, but if we don't look for them, we'll not find them. So we need to look. Very, very well. Thank you. Very well. Good comment. This one? This one we'll need to do a LEAP and go to the OR and do many biopsies here, or just a blade or the laser or whatever we have available. Okay. One more. How about this one? Is this suspicious for cancer? Is this suspicious for cancer? High grade, right? So no cancer will continue. Can we see the squamous columnar junction? No, right? The lesion is going everywhere here and go inside the canal. And here they try to open, so we could try to see the end, but we cannot see the end, right? There are some vessels here, abnormal vessels. They're all curly. So let's do a LEAP in this patient. You all agree? Okay. I have no idea of the time. Last one? Okay. Do you think this one? Is this suspicious for cancer? No. No. Can we see the SCJ? This one is very interesting because here we cannot see the entire SCJ, but they open here for us. And it seems we can see there's something covering and some secretion, but if we clean, there's a possibility that we'll see the SCJ. And now the lesion is going inside the canal, but they open the canal for us, and now we can see the end of the lesion, right? So of course for this one we need to be careful because there's secretion. I cannot see now. We're with the stuck image, but here there are a lot of vessels. So we should. What do you think? What should we do with this patient? Biopsy. Okay. Or do a LEAP, right? Okay, I agree. The trainee that is with us, they might know the subject, but they have questions. They like to ask questions, and we love questions as mentors, right? So every question is important. Everything that someone will ask you, you should give your attention. You should really tell them that this is an important question, because it is. And maybe he has a very simple question he does not want to do, but she was able to do it, and he could hear what she was saying. So every question is important. Everything that our trainees will bring to us is important to discuss, and we should always encourage. We should not say, oh no, this question is terrible. We should say, oh, thank you for your question. This is great. Let's see if somebody else has the same question and just bring to everybody. I think this is so important. We don't see this is in a book, but as we are here training trainers, it's very important to say this little, like, small things that makes a lot of difference. And I think for now, what we have next is yeah, I think it's fine. I think we talked about this, and when we are in the stations, Rachel and I will emphasize a little more how you can teach and how you can mentor your mentees. And I'll give to Susan.
I'll be very brief because I know we want to get to the station. So if you could just bring up the last one. And we can skip through all these, Darren. Go ahead and skip through. This is we've already talked about Dr. Salcedo, but we've talked about the need, cervical cancer incidence, WHO elimination, the prevention process. Go ahead. So IGCS aims and project. So the goal here, why did this start? Why did we come here? Why are we here today? So we do. My name is Susan Ralph. First of all, I'm mentorship and training program manager for IGCS, and we were doing invasive training in countries, and what we found out is there was no pre-invasive training. So Mila Salcedo and Dr. came up with this training to help people. We know there is ASCCP doing this. We know other people. We're not trying to compete with them. We're just trying to get to the places that don't have training. So it's so important that phase 1 and phase 2, as Rachel said, for the Belize group, and it's a lot. But the goal is the hope is all of you will become trainers, and you will be trainers, and then you will have a resource to have phase 1 and phase 2. These people can go and do phase 1 and phase 2, so before they come to you, they will understand. They will have a basic knowledge. So that's why I talked to several people last night, like, that was brutal. I'm like, yes, it was. But the fact that and if something changes, we will change it in this. That's what's happening now. We formed a work group to go look what updates do need to be made. Can we make these videos shorter? Can we make it a little bit easier? Can we make it, so this is what's happening now because we've listened to feedback. And so there's so many different things that we're trying to do to help. So if you want to go to the next, just to show where we are now, go ahead. So how it works. So phase 1 and phase 2, that's where you've done the online. You've done phase 1, which is the online training. This is phase 3, the in-person. So here's been our challenge, and this is what I want people to understand. So some people have come to a workshop, and they're like, where's my certificate? Well, we don't want to just give you a certificate now. This group is unique, and we are trying to do that. We're going to see, but you want to give you a certificate after you've gone back and done 20 colposcopies and 10 treatments. So the goal is we need to identify mentors. So this has been our biggest challenge today, identifying mentors. So thanks to Dr. Butler, who's helped us with, identifying the right group to be mentors, because the goal is for you to go back. Somebody can do 1,000 colposcopies, and if they're not right, then what are we doing? So we really want to make sure that the right mentors are looking to see, are they doing the right colposcopies? Are they doing the right treatments? Are they doing them the proper way to actually help patients out there? So it should be phase 1 and 2 is online. Phase 3, they come to a workshop, then they go back to a mentor to do the colposcopies and treatments. And then after that mentor says, yes, this person, again, even if they have to do 100 of them, but now you know that they did it, then that's your job as a mentor to make sure they've done it the right way. Then you say, yes, Susan, they're ready for a certificate, and we're going to give them that certificate. And then eventually, identifying more and more mentors. But Mila is going, a huge thank you to Mila, who went to Mozambique, then to Portugal, then to New Orleans, and arrived here at 12:30 last night. So she can't do it all alone. But thank you so much, Mila. I want a huge thank you. Yes, I mean, this is her dedication to doing what we're doing here. So this is why we are all so passionate about it, because she's so dedicated to it. We did New York, Seoul, and then Antigua and Mozambique. Well, yeah, but that was before this was this way. So this is really like probably our 6th or 7th course. Yeah. Well, yeah, MD Anderson has been doing this for years. So MD Anderson, thank you for being part of our group and kind of helping us with this. So this is really only 6 or 7. So this is a big deal that we are here to help, identify mentors in the region. So this is just something I want to show you. We've had 491 enrollees from 97 countries. So this is, that is a huge, we're getting to that 500. And then the next slide, Darren, is just how many people have completed it, which you are all part of, 190 from 61 countries. So it's a huge impact we're making, and we're thrilled. And then we will have all those people's names and email addresses to tell them, hey, this just changed. This is what's happening now. This is something we should all be aware of. So it's a huge thing. So thank you all.
And we want to thank the International Gynecologic Cancer Society. Susan, I understand this is the 9th training session that IGCS has embarked on. And of course, the MD Anderson Center. Melissa Veron.
Yay!
Rachel Ash.
Rachel.
And of course, Mila Salcedo. And we appreciate your patience with us, your teaching techniques, and your creation of a wide exposure to an area which we as gynecologists continue to learn more and more, even though we are doing it for a long time and some less time. So, of course, it would not be a closure unless we also thank our own Dr. Raleigh Butler. And of course our own to Darren Halliday. And the man in Miami.
Yeah, where he is. Where he is.
Who has brought all the uncooked meat into the Troy has brought the uncooked meat into the scene.
Yeah, I hear that.
Curry Carlton tonight.
And of course, our distinguished colleagues from the Caribbean, your 2 days here and your friendship and camaraderie and sharing of knowledge and information is unparalleled. We look forward to continue working together and learning from each other and being together as one team from the Caribbean. Of course, we want to continue the connections with MD Anderson, the University of Miami, and the IGCS as well. As Denny was saying last night, he was one of the founding members of IGCS in the 1980s with Dwayne Thompson, Phil Dysire, and Paul Morrow from the MD Anderson where he was trained. So we have great footsteps to follow, and we will continue to expand our linkages across the world. So this evening is for me to say, on behalf of our great team, it has been a very knowledgeable experience. Thank you for the learning, the teaching process for us. And may God continue to bless you all and your staff. And may God continue to bless our colleagues and our patients that we look after. Thank you very much.
Thank you so much. We appreciate your kind words.